our ongoing faculty development series. And I just think this is the perfect topic for what we're trying to accomplish, giving feedback and how do we become better teachers. By far the most common complaint we get from our residents and our medical students is that we don't give anything we can do to be better. I think it's important. So we're lucky to have Chris and Jared spend the next hour with us and give us some tips and hopefully prompt a lot of discussion and exchange. So I'll turn this over to you, and thank you all for agreeing to do this.
Our pleasure. We're glad to be here, and we're glad to see so many people join us. So to get started, we'll talk a little bit about the objectives that we have today, which are to identify why teaching and feedback is important, to actually differentiate between teaching and feedback, to discuss methods of teaching at the bedside, and to review methods of providing feedback. So I'm going to turn over to Chris, who's going to talk to you a little bit about feedback versus teaching.
So as a little bit of a preview, we're going to kind of do a pretty big, a little bit of a world tour of this stuff. Rather than sort of diving into one way to do it for in great detail, we're going to give you a whole toolbox with the hopes that we sort of pique your interest in some of them, inspire you to go read about this particular method and then try it on your next shift. We're going to ask you for feedback at the end. So when we're done, I'd like to hear a little feedback on the content, about the level of what we've taught today, the breadth and depth. And was it appropriate? Was it helpful for you? Was it at the level that's useful for you as a faculty member? So at the end of our shift, I'll ask you for some feedback on that particular topic today. So feedback versus teaching, right? The difference really is we always start with teaching, right? Teaching, learning focused on patients and their problems. Stroke, heart attack, physical exam, the knowledge that we're imparting, right? Knowledge transfer is teaching. Feedback is focused on the learner, right? The performance of the student, of the resident in a particular activity. And the design is to improve their performance rather than improving their knowledge. So with teachers first, right? If we can instruct effectively, that will lead us to giving feedback effectively. You have to learn to be an educator, a teacher. You have to want to impart knowledge, and then you can work on coaching and working on performance, doing that feedback piece.
So why is this important? Why are we spending a half an hour, 40 minutes talking about teaching and feedback? Well, there's a couple of reasons. One is the incidence of bedside teaching, across the board has really declined. This is a study from a couple of decades ago, but they looked at the amount of teaching that was done at the bedside in internal medicine rounds, and it declined from 75% to just 15% a decade later. A survey of 50 medical school faculty members looked at found that didactic seminars alone failed to foster humanism amongst their students. Of 21 EM residencies, now getting really specific to our field, 50% of the greater than 500 resident respondents recalled fewer than 3 observed HCPs during their training. And so that's a really important point there. And then bedside teaching with medical students improves their access to feedback from faculty, which was regarded by learners as an important aspect of high quality teaching. And we hear this all the time when the medical school is talking about the evaluations that the medical students are doing of their clerkships, of their rotations, that feedback and getting taught by clinical providers at the bedside is really, really important. So we want to pause for a second. We want to hear from you all, whether or not you want to type in the chat box or take yourselves off mute. What has been your experience with students and residents? Do you think they receive enough teaching and feedback? And do they think they receive enough teaching and feedback? So we'll pause for a second. If you want to type it into the chat box, or if you want to take yourselves off mute, we'd love to hear from you for a moment.
My observation is I think there's a fair amount of teaching that takes place, and I'm always impressed with how smart the other attendings are that I work with. So I think the teaching takes place, I find I don't think that there's ever enough feedback. And I know I struggle with feedback and giving the students real ideas of how they could have done things differently. You know, I always struggle at the end of the shift filling out that form. What could have the student done better? How can I struggle with that after 40 years of doing this? But I always have trouble with that.
So some of the comments. Oh, go ahead.
Sorry. Hi, my name's Jenny. I'm just on audio. Sorry about that. I think I struggle the most with giving feedback to the learners that are doing a really, really great job. So your exceptional residents or your exceptional medical students, and the medical students is a little easier than the residents because you can usually find something because of their level. But once you get to the level of the senior residents who are wonderful, to how to take them even better is really hard.
Yeah, we're going to talk a little bit about that later on as well. In the chat, we have, that they don't receive enough feedback, that they receive enough teaching, but not necessarily enough feedback, not enough from both accounts. So I think there's a lot of opportunity from both perspectives, and I'm sort of scanning through the comments here.
I think it's interesting. You're actually the second person. I emailed this question to a couple of people, and another person responded that exact same thing. Like, I struggle with giving feedback to the good residents. And everything went well in the shift. What do you say that's actually useful, right? So interesting that like multiple people in this very brief number of survey came up with the same idea. I think this is interesting too, that med students get more teaching than residents. An interesting thought there to chew on for a minute. Like, why is that? Why do we do that? Receive more teaching in the past than we think, right? And we'll talk about this a little bit too, about perception of teaching, right? Did they think they receive enough teaching and feedback? And how do we make sure that's evident when we're doing that teaching?
And I guess the last comment, I think they receive more teaching than in the past, more than when we think, but everyone feels like they can always do more, and everybody feels like there's a lack of feedback. So probably also thinking about this feedback that we provide to the students or the residents, but are we also soliciting feedback from them as well? So remember, that's a two-way street. So one other question, and I just want you to sort of think about this for a second. Do you teach or give feedback to the PAs, the nurses, the techs, the BAs, EMS professionals, other people who you come into contact with on a daily basis? We sometimes think about the medical students and the residents, but how about everybody else who's a member of the team, and are we giving them feedback? And if we're able to give them good, effective feedback and solicit feedback from them, does that make the whole team work better and make the entire episode of experience of care a better experience for the patient at the end of the day? So not looking for your input on this at the moment. If you're wanting to give it, we're welcome to. But we're also just wanting to plant that thought. And then I see a comment in the chat that the biggest confounder to universal techniques is identifying the learners who need pedagogy versus andragogy. So the higher level learning and adult learning techniques. And so we'll talk a little bit about that as well. So why bedside teaching and feedback? Well, without feedback, mistakes go uncorrected, good performance is not reinforced, and clinical competence is achieved empirically or not at all. And I think we know this. Bedside and rounding increased the amount of discussion about differential diagnosis, overall questions, and led to changes in the diagnostic workup compared to board rounds in the emergency department. And a really important point is that faculty can excel at both clinical productivity, because that's something we always hear, productivity is going to suffer if I spend more time teaching, but studies show that you can excel at both productivity and education. Highly efficient clinical productivity actually correlated with excellent resident teaching in many of the studies. So that's just another piece to keep in mind. So we wanted to pose another question to you, which is, what challenges have you had with feedback and teaching? We heard one of them already, which is, how do I give feedback to someone who does things really well? And we'll talk about a mechanism to do that and to engage with people who do things really well. But what other challenges have you had with feedback and or teaching?
Well, of course, I'm trying to show people how to have very brief but pointed goals of care discussions. That can be tough. I am reluctant to pull people away from their other multiple responsibilities. On the other hand, this is supposed to be done in private. I don't have a whole lot of trouble being able to tell somebody that was a great referral, or you did a wonderful job of getting all those forms filled out before you even called me. But my big problem is pulling people away from other things.
Okay. I see someone said competing priorities, always a challenge.
Especially in the ER. I think the other comment in the chat, it relates to the same as the whole, pedagogy, andragogy, but it's really about identifying your learner, understanding where their gaps are and what they need. When you have so many different learners, how do you understand in that one shift you're working together where they are? Okay, so let's get into.
Yep.
Yeah, sorry. Let's get into some specifics, right? So there's a little list from one article about some of the problems, right? I think this is probably the most important one. Clear objectives and expectations. If the residents know what to expect and the students know what to expect and what your objectives are and what their objectives are, it makes all of this much, much easier. Now, we'll go through factual recall. So this is the whole teaching versus coaching. Right, but do we focus too much on imparting information and talking about things they could read in a book, versus talking about the approach to something? We spend too much time talking about which antibiotic we use for otitis and not just saying, go read about antibiotics and otitis, but let's talk about how do we examine this kid's ear with a nervous mother, right? Pitched at the wrong level, right? This is understanding your learners, right? How do you know in a brief period of time in a short encounter what level they're at? Because we sometimes talk about their heads. I get surprised sometimes just the other shift asking about supracondylar fractures and their classifications with one of our senior residents, and they were like, no, I don't actually know those things. So, oh, okay, I assumed you did and was talking about how I apply it. Let's go back and talk about the actual content for a second. Passive observation, right? This is what you're doing now. You're watching Jared and I talk, not the ideal learning environment, right? Active participation learners, how do we pull them in? Supervision, provision of feedback, right? This is the whole thing where we're here, right? This is an age-old problem. Opportunity for reflection and discussion, particularly in ER, it's busy, people coming and going. Teaching by humiliation, I don't know if this is our biggest problem, but it's certainly something, being in an environment that's supportive, and we'll come back at the end. I don't necessarily mean being nice, I just mean being trustworthy. Informed consent from patients. This is sort of an interesting thing to chew on for a second. Later on, think about what your involvement of the patient in your teaching is. If you ever talk to the patient and said, hey, do you mind for a second if I spend a couple of minutes teaching this resident about you and your disease right next to you? Is that cool with you? What do you think about that? And when you're back at the desk, sitting at the computer talking about a patient, you think about sort of, if you were doing that same thing at a bar and telling the story about that patient, would they be offended by the way you're framing it? Would you want to be talked about that way, right? Respect for their privacy and dignity. It's very easy to get caught up in like, oh my God, you won't believe what this guy did, right? And not spend that moment thinking, oh wait, this is a human being that I need to interact with and model for my residents as well. Of course, congruence with the curriculum. This is what I think is really interesting to chew on for a second. Imagine for a moment if when the residents were learning about cardiology in conference, they were getting taught pearls about cardiology on the floor. Or imagine if we had physical exam month, where in conference they're doing physical exam skills. On the floor, everybody's showing them physical exam skills at the same time. Like imagine if we could build our clinical teaching into their curriculum at large. Wouldn't that be interesting? Rather than just a one-off of whatever you happen to feel like teaching or happen to show up that day.
So we started off talking about the difference between teaching and feedback, and I just wanted to spend a couple of minutes talking about some different bedside teaching methodologies. And we're going to go through this super quick. There is an article which is listed at the bottom here, and we can share it. If I can share it in the chat, I will, which goes into more details about this. But if you look at this screen and you're saying to yourself, I have no idea what any of this means right now, it may be worth your while to dig a little bit deeper, because these are some basic teaching methodologies for the bedside clinician. You may do these anyway. And so, it just might be putting a name to what you already do. But the Socratic method, it's this asking what if questions from a case study or whatnot, and then going down a little bit deeper, then making those questions a little bit more targeted, directing the questions at specific team members, and as Chris said, based on their level. And so you may ask the same question of the medical student and the junior resident and the senior resident if needed, or you could sort of work your way, as you work your way up the ladder in terms of their seniority, asking the same question, see how their answers differ. So there's a multitude of different sort of mechanisms to be able to get to the answer there. So this next one, the Aunt Millie, it's where the learner evaluates the patient and then presents only the chief complaint and their presumptive diagnosis. And this is about pattern recognition, right? And so this style is really about getting really good for your common disease, common complaints, and it really gets them to start looking at the patterns that may emerge. The 1-minute preceptor is something that I've learned about for a number of years, and there's sort of 5 steps to this. It's get a commitment from the learner on what they think is going on with the patient. Probe them for supporting evidence. So what do you think is going on, and why do you think that? And then teach them some general rules pertaining to this patient and to the case, and then reinforce with them what was done correctly and provide positive feedback, and then correct any of their mistakes. And this is a really important point, because we're going to talk a little bit more in some detail about how to give feedback to the person who does things well. Well, here's one way. Get them to make a commitment and own their diagnosis and their plan, and then give them that feedback that they actually did it well. SNAPS is just an acronym. It stands for summarize the history and physical, narrow the differential, analyze the differential by discussing the differences, probe by asking questions, plan your patient management, and then select a related clinical issue for additional self-directed learning. So it's adding on this piece of, hey, when you go home, take a look at this, read up on that. ED stat, expectations, orient the learner to what you're expecting of them. Diagnosis of the learner, determine their learning objectives. And maybe this is something you do before the clinical shift or early on in the day. Set up, use a specific patient care scenario, teach them, focus on those high yield, concise, relevant pieces, assess and give them feedback. And then remember, you're the role model, right? Always be that teacher. The learner's always watching you, implicitly learns a great deal from you and the way that you interact verbally and non-verbally with the patients. And then teaching scripts, right? This is the thing that you keep in your pocket that you're ready to pull out and review on a quick moment's notice. And there's a little bit of downtime. Let's talk about this, or hey, let's look at this case that we had a couple of weeks ago. A few of these things that you're thinking about. Maybe you pair this to what they're talking about in conference. Maybe you're thinking about what's coming up next week in conference. And so you can always have sort of a teaching script available. And Chris mentioned, right, there's no one way. It all depends upon sort of what your comfort is and how you go about it. And so if you're not familiar with these methods, right, sort of a one-page reminder. And I know the reference got cut off a little bit here, but we'll make sure we get that to everybody. I know Chris put it in the chat as well. It's by Chennai et al. And it's taking advantage of the teachable moment. And so here's sort of that one-page reminder of those different
All right, so yeah, let's talk a little bit about questions. So and again, that was a quick tour, right? That's 6 different bedside teaching techniques you can use, right? I recently heard an IME lecture, the Meta Grand Rounds was just on 2 of those for a whole hour, right? Like these things take a little time. You got to read about them, think about them, try them on, practice it a little bit. Like anything that's prescriptive like that, it feels awkward for a little bit, but it'll come on there. So just spend a minute on questions. We're talking about closed questions versus open questions, right? Closed questions are great for facts, baseline knowledge. What's the treatment for this? When do you give this medication versus that medication? Open questions are better for conversation. They're better for gaining understanding more about the depth of their knowledge, about their experience, about their comfort level with something. Taking something, instead of saying, okay, that's your plan. Let's talk about that. Talk more about, okay, what else did you consider doing? Right? What are the other plans you thought about when you were coming up with this one? And why did you choose this one in particular? Versus just saying, well, when we get this, we do this, right? Giving time for the students to respond, right? This is one of the hardest things for me, because I like to talk So it's very hard to stop for a second, let the student come back and talk for a little while without jumping on and trying to give them the answer for them, right? And trying to help them out, right? Follow a poor answer with another question, right? This is an interesting trick, right? This is Yoda, right? And the Socratic stuff. And, they give you the wrong answer, the answer you're not looking for. Ask them a question about why they gave you that answer. Or say, that's interesting. I would have approached it a little differently. Tell me a little bit more about that. Follow a question with a question rather than just sort of stepping on it, like, nope, that's wrong. Do this instead. Don't answer the questions for them. Give them a chance to really come up with it and get into depth with your responses. Statements can make good questions. Sometimes this can be complicated. Being non-confrontational, we'll come back to this a little bit. You don't need to be threatening to be challenging, but also you don't need to be nice to be non-confrontational, right? But if you're supportive, if you're fair, if the expectations are there and they know what to look for, rather than it's a humiliating situation, you're propping them up, helping them get better. At the same time, then you have to explain after you answer the questions, and then you have to give them some more explanation about what you're thinking about, right? So a couple thoughts to chew on for that as well. So this is where we are with what we talked about earlier, knowing where your student is, right? Give them a second to talk about their understanding of the disease or the patient or why they came to where they are before you start teaching them. Check in, know where they're at, right? Small size chunks. Don't launch into your 30-minute dictation about chest pain right away. Take something that's very specific, give them that knowledge, move forward, little bits at a time. Broader context, right? This is super important, right? Let's take what we just discussed on, on SCFE or on transient synovitis, and let's take that, and how does that apply to our broader approach to children with a limp, right? And this is a great moment for the learners to understand they're being taught as well. Like when you take it away from that particular patient and say, let's talk about what we just discussed and broaden it to the general population for the next patient that comes in with a singular complaint, or our approach to this particular disease in general, right? Or the physical exam on children in general, right? That makes it very obvious, like, oh wait, they're teaching me something larger than just this patient. I'm being taught now. So I think this is an important one. It really makes a big difference, right? Summarizing, right? Stop for a second, talk about what we've covered so far. And again, asking them their understanding, have them summarize for you, right? Talk to me a little bit about what we just discussed, and let's make sure we're on the same page. Take home messages. This is a sim thing. We do this a lot at the end of a lecture or at the end of a thing. We'll do it for you guys. It's always in the little evals people fill out, like, what did you learn today? Right? But it's actually really powerful. If you could take for a minute and ask a resident at the end of their shift, tell me something you picked up on today, right? What did you learn today from our conversations? Sometimes you'll be surprised what they come up with. Sometimes they learn something you didn't intend, or that may or may not be accurate, and you want to straighten that out, or you'll be surprised they picked up something for you need to teach. But it also is another way for them to walk away and be like, oh yeah, I did learn something before I left. Okay, let's get into feedback for a little bit. So take a second. If you got a piece of paper, you don't actually have to write it down. You can do it in your head. Some people like to see it in their pen if you're a visual learner. In 1 or 2 words, what's the primary reason you don't give feedback more often? I can tell you the top 3, but I won't give it away. I won't give you answers for you, but just something to think about before we get into this too much. How do you react when receiving feedback, right? Receiving feedback, right? We talked about giving, but how does it feel to get feedback? And why don't you ask for it more often yourself? When's the last time you asked directly from somebody, whether it be a student or a supervisor or a chairman or your director or whoever, a colleague, for some feedback yourself? Why don't you ask for that more often?
So as you're thinking about that, you don't have to share. We're going to talk a little bit about the levels of feedback. And there are 4 different levels of feedback. And the most common one, as Chris talked a little bit about before, is the task level of feedback. right? Telling them how to tie a knot, fill out a form, place an order, even intubate. It's really focusing on that task level. And we give this feedback, but it ends up, doesn't necessarily make a long-term change. It causes a change maybe for the moment, but it doesn't necessarily cause a long-term change in them. And then there's a couple of issues with this, right? So if you give too many suggestions, the learner goes into this, just finish this goal, get this task accomplished, because they don't necessarily want to keep getting all this task feedback, do this, do this, do this, do this. And then if it requires an extreme amount of focus, they might not even be listening to you, right? Because they're so focused in on what they're trying to do. The next level of feedback, and the next two are highlighted a little bit because we want to call a little bit of special attention to them, is the process level. And this is the process needed to understand and or perform a task. We're going to talk in a minute about a concept called double loop learning. And that's really what this drives home to, is looking at why they did it, how they did it. And so it's not on the, not just on the how, but the why component of it. And then the self-regulation, this is the idea where an individual has this sort of self-monitoring, directing regulation of actions. They're confident in their own ability, but they're also open to asking others about their performance, right? So this individual is really confident in their ability to assess a patient, but they know that a colleague or a faculty member is also really good. So they're comfortable explaining their approach and then asking for input or suggestions. And I think this is something that we get better with as we get more confident, and something that we want to try to instill in our younger learners as well, which is, hey, if you're comfortable with it, ask a colleague, ask a faculty member for some input, because there's always things to learn. There are some challenges with that. From their own mentality, what if their colleagues laugh at them? What if they ridicule me for my technique? But it really does help people, grow and develop themselves. And this last one is this self sort of level of feedback, right? And this is where we usually give somebody really positive feedback. We give it to the learner, hey, great job. That really went well. It doesn't necessarily provide any substantive feedback for them. So we really want to focus in on the process. Going forward, we're going to focus in on the process, and also for you all and for your residents and students to think about the self-regulating part, and even for yourselves. And so, I think I'm going to actually pause here. I think Chris is going to take this one.
Yeah, so a familiar site on the left, perhaps. It's I guess I can take the bold move of using a curse word on our lecture here. It's the shit sandwich, right? So positive feedback, say something nice, give them the thing you want them to work on, and then say something nice again. This is a favorite of people who aren't very good at giving feedback and are really uncomfortable doing it. Why? Because it makes you feel like a good guy. Like, I'm being nice to you. I'm giving you 2 compliments for every one thing I think you need to work on, right? And I'm ending my conversation with something positive, right? The problem with it is it's really obvious, right? The learner, hears that middle part. And it doesn't really matter that you said something before or afterwards, especially if they're artificial. Calling in the chat, I was talking about sort of putting people in the spot, whether you're getting genuine feedback or not, right? Just saying like, hey, you did a great job, you saw a lot of patients, doesn't decrease the impact of then you correcting on the way they give their history and physical, right? Especially if they're not set up to receive that feedback correctly. It's funny, I've been primed for this, so I've been asking our learners a little bit about it. And one of my learners yesterday was like, but I like that sandwich, right? I like that technique as a receiver. But I asked her a little bit about why, but what it comes down to is it's nice to hear good things, right? And especially if you're not super confident at the moment. So I'm not saying that the loss of the sandwich doesn't mean you shouldn't give positive reinforcement for good things, right? Yeah, there you go. Nice hat, your face is ugly, I like your shoes. Yeah, there we go, Colleen's got it. But it doesn't mean you can't say good things. And positive reinforcement is every bit as important. We do this in a debrief after a code, right? It's just as important to say, hey, we did this really well in this resuscitation. The next time someone comes in, let's do that thing again, right? As it is to say, we didn't do this so well. Let's change it for next time. You don't have to structure it this way. What's better is the sort of triangle of giving, soliciting, receiving. If everybody on the team is comfortable with the idea and expecting to receive feedback, when you receive it, it's not so negative, right? Because I asked for it, right? Because you knew it was coming. Giving feedback the same way. If I wanted as an educator to get feedback from you by asking you at the beginning of the shift, hey, when we're done, I'm going to ask you about this thing. It makes it easier for them to actually give you critique because you asked for it, right? It's a little less uncomfortable that way. And soliciting, again, role model this, right? If the learner's asking for feedback, you're more likely to give it. If you ask them for feedback, they're more likely to reciprocate and ask for feedback as well. And then it lands better. You don't have to frame it with nice things, as long as they're looking for it and they're expecting it. So people are having fun with the sandwich on the side, but that's great. Yeah, next slide, Jared. So let's take a second for sort of like, how do we do this when it's something we do want to actually give you feedback about, right? So one, again, clear expectations. We've been saying this since like slide 3, right? How do you want to receive feedback? When do you want to talk about it? How do you want it? What are you thinking about? What are you working on yourself? Direct observation. So this is what my wife in the business world calls camera check. When you're giving somebody feedback or an evaluation, give it in a fact base, right? I saw this, right? I heard this. When you were interacting with your patient, this thing happened, right? Rather than a judgment, rather than sort of an opinion, rather than saying, your physical exams aren't very thorough, right? Well, that's a judgment, because what I'm saying then is I'm saying, Margaret, you're not very thorough, right? But if I say like, hey, I noticed when you did your auscultation, you only listened in 2 spots of their chest in the front, and you didn't listen to the back. That concerns me a little bit because of X, Y, Z. That's a fact, right? It happened that way. I noticed you really struggled to look in that kid's ear and they were moving quite a bit, and that can make it difficult to get a good exam. Let's talk about how to do that better, right? It's not that you stink at looking at ear exams, right? Let's go with the facts, right? Give them something that's fact-based, observable, camera check. And it gives you a specific behavior that they can actually change, right? I can't change that I don't know, if you think they're lazy or they're slow or like, that their exams are no good. You can't just say that and they'll get better. You have to give them specific actionable things they can change. Coming up with an action plan is super helpful. So next time, how are we going to do that? That might be a little bit better. And then always follow up is important.
So I mentioned this briefly before, this idea of this double loop learning and focusing on the process and the process and the learner's ideas behind it. And so what we oftentimes do is we focus on the strategies and techniques, the what we do. So we see somebody struggling with a specific skill, and we correct that task. We correct the way they're holding the instrument. We correct the way that they're listening or doing whatever it is that they're doing. And that's a single loop, right? We're just problem solving. We're improving the system as it exists. We want to take it back another level. And that's not just fixing the problem, but uncovering their thought behind it, their assumptions behind it, their values and beliefs behind it. So why are you doing this? Explain to me more. And this works whether or not they had a good result or a poor result. Just because somebody did something well doesn't mean they knew the reason that they did it. Just because they did something well doesn't mean they didn't just get lucky. So the opportunity here is to say, hey, I noticed that you did this. I thought that was really great. Tell me why you did that. Explain to me more about that. And we're going to talk a little bit more about that in the next couple of slides. And so I'm going to turn it back over to Chris. And Chris and I have the same ideas, and we sometimes use a little bit different words for this, but at the end of the day, you should choose the 3 sort of key phrases. And I think Colleen even alluded to this in the chat a minute ago. Find the 3 sort of key phrases that resonate with you and that stick with you that you can go and employ, because this is what's going to get you and your learners to that double loop process so that they can change the reason that they're doing things or continue to do what they're doing, but understand that it was the right thing to do.
Yeah, Yeah, so this is an academic advocacy inquiry is an academic simulation debriefing technique that, like, there are a billion papers and talks and lectures done on, but essentially, you know, the catchphrase for it is debriefing with good judgment, right? So it's giving feedback with good judgment. It's not no judgment, right? You can't give feedback without judging what somebody did, right? If you're going to tell them that they did something wrong, you have to judge that it was right or wrong, right? But how do we do that in a way that's supportive and curious and knowledge-based and double loop rather than just feedback on the specific thing that just happened, right? This is what we're talking about. Here's that camera check again, right? I see. For me, I start with, this is what I saw, right? This is what I heard. Or to Colleen's point in the chat, this is what I didn't hear, right? Here's that fact-based thing. This is the thing we're going to talk about in specific. Then I move to, you know, I think. And this is an interesting turn of phrase. We don't do this a lot. You know, I saw that you did this. That concerns me a little because, you know, it could lead to this or that other thing that's not so good, right? Or, you know, I might approach that a little bit differently. In my experience, I find this other way of doing it works better. Right up front, you're telling the learner why we're discussing this thing, right? It's really trying to avoid that idea of, you know, I saw you decided to do this thing. Why is that not a great idea, right? Or, you know, why might you do that differently? They don't know, right? That's why they did it that way, right? So telling them up front, this is why we're talking about it. Here's what I think right off the bat, right? Here's why I'm asking you and why I think it's important. Gives them a chance to chew on that and then respond to you in a way that makes sense in the frame of what you're trying to teach them. And this is where we get to I wonder. This is that double loop. So in the academic literature, we call it genuine curiosity, right? So it's like, I saw this thing. This is what I think about it and why I might have done it differently. I'm curious, right? Why did you choose that approach, right? You've already given them the reason that you think it might have been different, but instead of saying like, you're wrong, this is what it should be, I'm gonna ask you why you did that. Or in the same way, you can say, you know what? I noticed that you had a really great interaction with that angry patient and you de-escalated them and spent some time. I think that's really great because it's not easy to validate somebody's feelings like that and get them to come down from that emotional edge. That was really great. I wonder, did you do that intentionally? Right? I'm curious, did somebody teach you that technique or is that something that was more natural to you? Let's talk about why you chose to respond to the patient that way. I see, I think, I wonder. There's a lot of other ways to say it. Jared had, what did you say? I saw, I thought, I noticed.
Yeah, so my frame is like, I noticed, right? And I approach it from I noticed because I may not have seen everything, right? I might be at a little bit of a distance, and what you experienced and what my learner experienced may not be exactly right. I may not have seen everything. So I use the term, I noticed that this happened, or I noticed that you did this. And I think, right? So I thought that was really good because of this, or I thought that was really interesting, or I'm concerned about it. And this piece, this I think piece is super important because if you don't use this middle component, your learners you're playing a guessing game with your learner. And your learners are then saying, well, was it good or was it bad? Should I answer them affirmatively or should I sort of cover up what I did? But if you lay out what you were thinking, it takes that edge off of it. And then this open-ended question, right? And whether it's I wonder or why did you approach it that way or tell me more about that, you know, explain to me this, you know, whatever those key words are for you is gonna, whatever's gonna make you comfortable with using this. There was a question in the chat, Chris. Do or should these techniques vary according to what level of learner you're dealing with, an MS4 versus a PGY4, for example? And I know Colleen is responding to it. You know, I think somebody's frame, regardless of what level they're at, and you can then teach them where there's gaps or reaffirm that what they did was correct, depending upon what level they're at. So I think it's usable for just about any learner. But Chris, what do you think?
Yeah, no, absolutely, same thing. And what Colleen is saying is you know, sometimes younger learners, you know, or students and folks, you end up doing more sort of straight teaching versus anti. What that really means, you're doing more teaching than you are giving feedback. And that's, you know, again, for a senior resident or a fellow, right? What they really need probably more of is feedback, because they've read the book already, theoretically, or read the articles or gone to the lectures, right? So they need less of necessarily the knowledge transfer and more of that feedback. You know, and for the teaching techniques, for sure, like at the med ed grant rounds we had recently, we talked about sort of that 1 minute preceptor versus the SNAPS technique and things, where like SNAPS is a little more autonomous, is a little more adult learning theory. So it might be better for more advanced learners like fellows, where 1 minute preceptor is a little more basic. Ask me something, I'm going to teach you about it, which is a little better for junior learners. It's a little more of that information transfer teaching than it is feedback. But yeah, but this is, you know, anytime you want to get into the why somebody did this, this is a good technique, and especially powerful for feedback. Because again, it gets away from that necessarily for the shit sandwich, right? Because it's no longer, this is a bad thing that you did wrong. Just, I noticed this, I might have done it differently. Let's talk about why. Instead of just a direct, like, that's not the right way to do it. You should do it this way next time.
And Colleen brings up a really great point as well, which is when you use this with colleagues or even senior learners, it's about being inquisitive yourself. And so you end up learning as well. I remember there's been times where I use this approach and I said, you know, I noticed you did this, and that's not the way that, you know, any book says to do it. Tell me why you did it that way. Explain to me more. And they had this amazing answer, and it changed my practice. And so there was just some really interesting things that come out of this if you go into this with a sort of an inquisitive mindset. And so, you know, we're going to talk real quickly about soliciting feedback and what that means, and from the receiver perspective, right? Because we want faculty to also be asking, and residents to be asking for feedback. But so go into this early, right? We've talked about this again since slide 3 about setting your expectations, but request it early. Chris laid that out for everybody. We want to hear your feedback at the end of this. Highlight exactly what you're looking for. And Chris did that. He said, we're going to ask you about the content. Was it at the right level? The mechanism of delivery, so on and so forth. Choose specific people to give the feedback. Make sure it's directly related to your goals. Use a helpful opening phrase, right? So I think I may have missed something on this patient, or I missed this particular reaction or this component. What do you think? Ask for recommendations, right? Never compare the feedback from others, openly, clearly. Thank them for their information. Decide what to do with it. And if they give it to you, if you utilize it, make sure you tell them. And then consider it one data point, right? One piece of this puzzle. And then I just mentioned this one. If you do use their feedback, let them know that you actually did use it and what the outcome was. And if you're the sender of this feedback, right, create a supportive environment. Again, setting that expectation early, explaining how you're going to do it. Privacy is nice, but not always guaranteed in our environment. But realize that they're asking for guidance, not necessarily criticism. Clarify what they want feedback on, and then listen to their self-assessment and respond to it. When finished, ask if it's what they wanted to know, right? So did I give you what you were looking for? Respond with respect, and then help the person create an action plan. Don't tell them what to do, but you know, help them formulate their thoughts and their next steps, and then check in with them. You know, how did it go? So a couple of quick things about the environment, right? Mutual accountability, willingness to learn, this inquisitive mindset, not being fearful, and also not having surprises, being truthful, having responsible language, and create that sort of coaching environment. But nothing here is talking about it has to be in the private setting, it has to be formalized. A quick check-in at the end for a couple of minutes. I watched 2 faculty members after a session earlier today. Hey, how do you think that this has been going? How has this gone? And they had a quick dialogue, and I thought it was great, because that's what not only we espouse, but that's how we improve upon the programs that we offer, and the teaching and the feedback that we're providing. We'll sort of wrap up with Chris here.
Just, you know, I have to put one good meme in any lecture, because, you know, I enjoy them. But again, so bottom line, right? Trustworthy teacher, right? The ability to deliver good feedback, to receive good feedback, the ability to teach someone in a clinical environment starts with trust, right? Starts with clear expectations and goals, right? You've heard us say this like 52 times, right? Start the shift with, this is how I want to run things today. Sometimes I'm going to follow you into the room. And when I do, I want you to run the show, do the H&P, and I'm going to stand behind you and observe that directly. And then sometimes I'm going to have you go and do it and then come back and tell me about it, and I'll do a separate one, right? No surprises. I was teaching my fellow yesterday about sort of how we do this, and we were talking about going with residents when they go to give their exam. They're like, well, but doesn't that kind of like step on their independence, right? But like, no, right? It gives me an opportunity to actually see them do their thing and coach them on it, right? I can't coach you on your physical exam if I never see you do it, right? I can't coach you like on your history taking skills. I can tell you like, oh, you missed this bit of history, but I can't tell you why unless I listen to the way you elicit that history, right? All about expectations. And again, goals, right? What's your goal for the shift? I want to give you feedback at the end of the shift. I want to make sure you ask me, what do you want to talk about at the end of the shift? Do you want it to be about your assessment plan? Do you want it to be about your physical exam? Do you want it to be about your ability to manage flow in the department for the afternoon because you're senioring for the first time? What's your goal? What do you want us to talk about? And that way, when we get to the end, they're going to expect me to say that. They're going to trust me that I'm giving them feedback they wanted, and it's helping them get better under their own power. Right? They're going to be working on, this is andragogy, right? Learner-centered or learner-driven, adult-driven learning, sorry. I'm going to learn what I want to learn, right? Right? So if I want to learn about this thing, when you start teaching me about it, I will listen, I will remember, I will respect that feedback rather than being confrontational and defensive about it. And again, you don't have to be nice, you just have to be fair and objective. Use that camera check. I see, I think, I wonder, genuine curiosity will get you that trust, and a good way to give that quick feedback at the bedside on the shift, and keep it trustworthy and receive feedback the other direction. Okay.
What questions do you have?
Thoughts, questions? It's like 42 educators here.
Well, I think that was really a great session. I think it's as basic as it is. It's it's a fundamental topic, which I think we'll revisit in this whole faculty development series. You covered a lot of material. It's very hard to get your hands fully around it. I think this reference, which I am imagining is your selected reading that you think educators should read, is I think a good resource, and we'll get this loaded up with your lecture. But it's a very, very tough topic to make real. And I don't know if simulated scenarios is a way of driving home some of the points. I'm interested from Shefali, the feedback she gets from medical students in the little books that we fill out, and from Elaine and the rest of the residency team. We talk about this. We don't do it well. I know we don't do it well. And I think this is a great beginning. If nothing else, this should have made everybody think about how we teach, and of course, how we give feedback and how we can do it better. But it has to go beyond just the 45-minute presentation. This was just the beginning of something key.
A win for me would be everybody goes and reads one thing about one teaching or feedback technique and tries it on over the next couple of weeks. All right, so I'm seeing some generic feedback, some positive stuff on the chat, some great talks and thank yous, and I appreciate that. Thank you guys for being here. It's amazing to have 50 people on these and really get to talk, because I know a lot of respect, and a lot of the folks on this chat could give this talk, so it's really an honor to get to do it. Talk to us a little bit about, I want to ask specifically about the topic. Thoughts on the content, the depth of content, the breadth of content. Was this at the right level for a faculty member? Did we cover too much, not enough? I would love to hear something specific from you guys that you think would be helpful if we were to do this again. And you could say it if you don't want to type it all. You don't even have to turn on your camera.
This is Colleen, but I think I've talked with maybe some of you about this before, but I think it would be really great for us to set up occasional kind of peer-to-peer like sort of feedback pairs or something like that, where maybe for a few hours on a shift, we both know about it ahead of time, and one of us kind of stays with the other and watches how we teach and give feedback, and then gives us feedback on how we teach and give feedback. I think that could be just a really interesting way to get some tips, learn how other people do things, and get a little bit of insight into what you're doing.
Colleen, this didn't you and Joff kind of think about this with your coaching
Yeah.
grant that you put together?
Yeah, we did, and I haven't heard about the grant, but I think that something like this. I mean, initially we were doing it more for the interns, where we were trying to make sure that interns were set up with a particular faculty member on multiple shifts, so that they could have some more continuity. But I also think that one thing that we really miss out on is an opportunity once we've graduated from residency to learn from each other. And I think, you know, it would be really a situation, I think, if we kind of set it up and we're very clear about what our goals were ahead of time, where I think we could really take advantage of this amazing faculty that we have. You know, we could like steal each other's little 1-minute teaching sessions. We could help each other get ideas for how to give and elicit feedback. I mean, you know, and I think we could do it in a way that, you know, not for a whole shift, but a part of a shift that you're on together anyway, where you could just watch each other. I think it could be something really fun and interesting and growth and inspiring.
A community of practice, if you will, centered on feedback and improvement. I think it's a really great idea. And I think, you know, Kedria in the chat said, I think Andy makes a good point about needing to try it out, and I think that's key. I think, you know, taking one of these ideas, whether it's a teaching methodology or feedback style, and there's many more, and playing with it and going over it and trying it. It is uncomfortable. It is uncomfortable at first until you see the results of it and get acclimated to it. And so trying this out or role playing it, you know, I know I'm happy to do so. Chris is, I'm sure, happy. Colleen, Heidi, those of us who do a lot of debriefing are really comfortable with this. And, you know, even via Zoom, you know, practicing, you know, so that you're prepared, and rehearsing is always a good idea.
And the other thing I think that doing it in the clinical setting to some extent would do, is that it would be it would model for residents something that this environment of coaching that we've been talking about trying to foster.
Absolutely. Jenny makes an interesting point on the side, maybe a request for a future lecture on the difficult learner, the learner who's less receptive to feedback or teaching. You know, I've given talks on the topic at other places as well. You know, certainly in the sim lab, there are the non-believers, and how do you interact with those folks? You know, I'll give you a preview. It sounds a lot like what we talked about today with clear objectives and expectations. You know, the way you overcome doubt in the sim lab is to acknowledge right up front the mannequin has limitations, and we know that, and we're not going to let it trick you. So that when we come back, we can have a conversation about what you missed. It's not about the mannequin, because we dealt with that already. You know, same idea with the shift. I'm going to give you feedback. How do you want to hear it? Helps a lot with their receptiveness to hear it. If you've asked them ahead of time how and when and what they want to learn about, and give them a chance for some self-reflection. But I think that could be a really great talk for the future. Thank you for the suggestion.
I see the last comment that was just supposed to, you know, struggling with teaching the unmotivated learner, like the off-service residents. And, you know, calling a colleague of mine down at Vanderbilt sort of calls attention to maybe what we would term inappropriate behaviors. And while they may not be exhibiting inappropriate behaviors like the unmotivated person, using the advocacy and inquiry component is really great for that. Hey, I noticed that you don't seem to be so engaged with this. You know, I noticed that you're, you know, not picking up a lot of patients or your body language. You know, I'm concerned because, you know, XYZ. What's going on with that? Maybe it's not that they're unmotivated. Maybe they, you know, have a sick child at home and were up all night the night before. Maybe there's other issues going on that you can uncover. So the advocacy and inquiry concept that we talked about is really useful, not just in giving feedback, but sort of inquiring and understanding why people are behaving in certain ways and uncovering the frames behind it, not just their actions. So that's one methodology of thinking
Yeah.
about how to
And
address it.
I'll kick the dead horse one more time with setting expectations again, right? Like if, hey, psych intern, I know you're not planning on dealing with a cirrhotic with belly pain and fever in the future, right? So let's at the beginning of your ED shift acknowledge that you're not going into emergency medicine. But what do you want to get out of today, right? Like, what are your goals for this shift? And what can we do that's going to interest and help you in your career later? Because I certainly think there's a whole bunch of stuff I can teach you as a psychiatrist in the future that'll be useful, right? But you've got to believe that. And if I start with what do you want to get out of that and then make that a focus, you may engage them more because now they know that you're there for them too, not just for your EM interns. You're not trying to turn them into an emergentologist. You're trying to show them what your field can offer them as a doctor in the future. Feedback session, yes. Sim sessions. This is back to the, should we be doing, sessions on practicing this feedback and observe feedback, and whether it's in the sim lab or at the bedside, right? Getting the opportunity to give feedback and have somebody coach you on that is really powerful and certainly something that's worth exploring.
Just a time check. We're coming up to the top of the hour. So we want to be respectful of everybody's time, but if there's any last question or burning point, would love to hear it. And if you have additional feedback for Chris or I, feel free to put it in the chat box. Feel free to email us. We'd love to hear it. If you have other suggestions for other things you'd like to hear about from the CMed lecture series, feel free to email any of us or Andy, who will put it into the rotation.
Yeah, this was great. It's one of many, and we'll keep looking into this topic and building on it. All these lectures are video archived, though I don't have the website yet, but it's coming up. Brett's responsible for that. Next month we have a talk on disparities, I think, in education, and the month after that is going to be on the Institute for Medical Education, because their applications will be coming up for the faculty who want to enter the IME. But I really appreciate everyone coming. 48 people signed in today. That's huge, and that tells me there really is a culture within our system to want to educate and want to improve, and I think that's beautiful.
Yeah,
So
thank you for taking an hour from your busy days to hang out with us. Really, really an honor.
Thank you, everyone.